Hi, I'm Dr. Eti Ben-Shabbat from Brain Rehab Academy, and in this video, I'll answer a question that I get frequently, and that is, how do you identify strokes? I'm going to answer not only how I identify strokes, but also what it means for rehab. See, when a person comes to hospital with a suspected stroke, they're going to need to have images straight away. The gold standard used to be an MRI, and the DWI and ADC are the sequences that tell you about stroke. Diffusion weighted imaging is DWI and ADC is apparent diffusion coefficient. The gold standard, though, has changed, and CT perfusion has become the new gold standard. The CT perfusion tells the clinicians, the neurologists and the radiologists, which area is the penumbra and which area is the core, the infarct core. So what can be treated and what can't be treated. And treatment decisions are made accordingly. So both CT perfusion and MRIs are brilliant in telling you about strokes within minutes. But you, as a rehabilitation clinician, want to know mainly what is the rehab potential of the person. Not just that they had a stroke, but how bad is the stroke and how they're going to recover. To identify rehab potential, you have to do three things. We discussed the identification of the stroke, so that's the first step. The second step is identifying what sort of treatment was given. You can find that in the notes, or you can speak with a neurologist and find out what the treatment was. And the third point is about identifying the success of the treatment. So did some of the stroke recover, or did everything that we saw in the initial image is what's gonna progress to an infarct? Now, the answer to that question is, of course, subsequent scans. So in many health services, there is a subsequent scan that will be taken a few days later. It can be either a CT scan or an MRI scan. Both of them will show you really well how much of the initial lesion progressed to an infarct. But sometimes you don't have those scans. Sometimes all you have those initial scans. I remember a case study in which I ran a workshop for last year, and the clinician was profusely apologizing for the fact that she doesn't have more images and all she have is the CT perfusion. And I said to her, but this is real life. It's okay. This is what's going to happen for some of our patients, and we need to know how to deal with it. So what did I do? I basically explained to them how you would go about assessing the exact location of the stroke as you see it in the acute images, so either MRIs or CT perfusion. And then once you know the exact location, the exact anatomical structures that are affected, then you can extrapolate function. Once you know what the functions that are going to be affected, then you can target your assessment a little bit better. If you don't have subsequent scans, you just have to assume that all of it progressed to a lesion. And if you find out in the assessment that some of the functions were spared, you know that some of it has recovered because of treatment. So there you have it. When you want to identify strokes, look for MRIs or CT perfusion. And when you want to determine the potential for recovery, look for subsequent scans when you've got them to identify what the final lesion is. And if you don't have them, you just have to assume that everything that you saw either in the initial MRI or the initial CT perfusion progressed on to an infarct. I hope you enjoyed this video. Please share it with anyone who you think might benefit from it, and I look forward to seeing you in the next video. Bye.